I'm Anthony Leeds, and you will recall that last week I spoke to my colleague, Mr Pratik Sufi, the senior bariatric surgeon at the Whittington Hospital in North London, and we discussed the role that surgery can play in helping people who are obese or too heavy, and in terms of achieving good, sustainable weight loss. But there's still a few other topics that we needed to cover, so let's continue again. Pratik, thank you very much for joining us again this week. And the topics that we should consider, last week we described the different types of surgery and the way in which it's done and so on, and the fact that weight loss before surgery may well be beneficial. We also mentioned that there is evidence for very good long-term benefits from bariatric surgery, and there are individuals who've been observed for up to 20 years or even slightly more now. In Sweden, for example, there's a set of individuals who are being observed, and the evidence from those is that the complications associated with obesity, there is a benefit which is sustained for some time. Can you tell us how far we are now with all the evidence for long-term benefit? Because these are the questions that everybody asks. So when we're looking at the new drugs, the duration of the clinical trials, 2 years, 3 years, 5 years, and so on, people always say, well, what's going to happen at 10 years? What's going to happen at 15? For bariatric surgery of the different types, what are the longer term outcomes in terms of weight loss maintenance and the remission of diabetes and the reduction of blood pressure and so on?
Thank you. So very good question. Regarding the benefits, it is well established that 2 years out from the operation, about 85% of bariatric surgery patients would have attained the goal weight that we're talking about. We're not talking about the best weight possible, but we're talking about the goal weight, which is usually for us, if we can get 70%, give or take 10-20% of excess weight reduction. So that's talking about anywhere between 50 to 90% excess weight reduction. Then we consider that a good outcome. Now, after that initial 18 months, 2 years, there would be a gradual weight regain, very slow weight regain, which is modest and only a small amount in the vast majority of them. I would say about 80% of patients would be able to maintain it long term. We know that some patients will fail, and we know also those patients who are more likely to fail. So we know that genetics has got some role to play. And the other thing, of course, is the environment in which the persons are living. So, for example, people who are doing shift work, particularly at night, or in very stressful jobs, and then these patients, or people who are taking psychotropic medication, then these patients are more likely to fail because these are obesogenic conditions. People feel more hungry if they're doing shift work at night. They're more likely to eat junk food, or if they're stressed, or if they're on psychotropic medication, or perhaps even steroids for other conditions. People may be on steroids for brittle asthma, or for control of certain inflammatory conditions in the body, but that can lead to weight gain by producing hunger. But generally, for the vast majority of patients, we expect that about 70%, 65 to 70% of patients that had undergone bariatric surgery would have maintained their weight loss. They might have put on a little bit of weight, but more or less they would have maintained that weight loss long term, going out 15 years, 20 years.
I mean, obviously, the other interesting issue is that the types of surgery have evolved in the 30-year period during which these longer-term observations have been made. So there's a slight change in the pattern of types of surgery, hasn't there been, during that time?
Yes. So there is a variety of interventions that are available, starting with procedures like balloons, which is not exactly an operation, but endoscopic procedure. Endoscopic procedures like endoscopic sleeve gastroplasties. And then, of course, we have got malabsorptive operations, which have completely gone out of fashion, like jejunal-ileal bypass or vertical banded gastroplasties. These are not done anymore. but the vast majority of the operations in the world is nowadays either a sleeve gastrectomy or a version of it, or a bypass of some sort. There are a number of bypasses. So there are proximal gastric bypass, or could say standard gastric bypasses, of which there are two mainly, which is the RY gastric bypass and the one anastomosis gastric bypass, also known as mini gastric bypass. There's nothing mini about it, but it's a single anastomosis as opposed to two anastomosis in the RY gastric bypass, which is the gold standard. Then there are more malabsorptive operations. So in the old days, we used to have BPD, the biliary-pancreatic diversion, which then evolved into duodenal switch. I don't think that anyone does BPDs nowadays. Duodenal switch, maybe some people do, but once again, the likelihood is that most of these patients will have a modified version of that. So they would probably have a SADS, single anastomosis duodenal bypass, in order to try and modulate and reduce the malabsorptive effect of the operation. So the vast majority of the operations would be any of these later operations I'm talking about. Mostly they would be sleeve. That's the commonest operation done in the world nowadays, very popular. Though the downside, of course, is that more patients get heartburn, indigestion, and there is more weight regain after 2, 3, 4 years, 5 years because of the obvious nature of the operation. But it's a simpler operation to do. It's easier to do in a setting where there is less health resources available, and it's less expensive. Then, of course, the second most common operation in the world nowadays is a bypass, a proximal gastric bypass, whether it is the RY or the one anastomosis. And then the other ones that we've talked about, duodenal switch or any variations like SADS, these are less common. And gastric band has fallen out of fashion, and though we still do them. There are some patients who want gastric band, but if one is going to have a gastric band, then they must have a great discipline in life, that they are not going to be tempted by bread and meat mainly. They might find it a struggle to eat other food as well, especially if they're eating fast, eating quick. So if someone is a teacher and will only get a 15 minutes break for lunchtime, or someone is working at a call center, then this operation will not be suitable for them. So it is also the environment in which they are that we take into consideration. Someone may be a candidate for a gastric bypass. Let's say a patient is diabetic and would be candidate for gastric bypass, but we look into the overall sort of background of this patient, and we find that there have been instances in the past when this person had self-harmed, or maybe the patient is schizophrenic. His patient may be stable now, but our concern is patient is stable now, but what would happen if the patient becomes unstable and has lost the insight of the medication that they need to take, after the operation, and they become non-compliant. So it's the vitamins and minerals that we're talking about, and then this patient may become more of a danger to themselves. So there are lots of things that we take into account when we advise patients one operation or the next or the other. But the commonest one is a sleeve gastrectomy nowadays in the world. I would say about 60% of the operations in the world, 65% is sleeve.
Just two observations. One is that for those who are having surgery that involves a degree of malabsorption, there is of course a long-term requirement for considering the consequences of the malabsorptive state on their nutritional status, isn't there? And there is a need to monitor on an annual basis, and also to take supplements to make up the deficits.
Yes, and it also depends on the nutritional value of food, and again you're talking about the holistic vision. As we know, that nowadays the food is calorie dense and nutrition poor, so nutrient poor. So we have got mass produced food which have got calories, but not necessarily good nutrients, including vitamins and minerals, especially in food that is grown in vast greenhouses on artificial felt and artificial food, rather than on organic method of farming. So all of these should be part of the global vision in managing these conditions.
Yes. But what we should also say, of course, is that the bariatric surgical team includes specialist dietitians, and of course you have educational programs for the patients, because the surgery is done, but there has to be an element of education and a revision of the patient's review and consideration of diet and what they're going to do in the future. And that may also need reinforcing at intervals as well, as we know is the case when it's a drug treatment or a dietary treatment. But you do provide that.
Yes, and but of course, like anything else, like for example, diabetes, as we know, the diabetes, yes, there is a case to manage them in the hospital in a tertiary setting, but the aim is that these conditions should be managed in the community. So if we can get the community trained, then bariatric surgery, post-bariatric surgery management should be in the community, because you just don't have the capacity to deal with all these patients. If let's say that if a unit is doing 500 operations a year, so in year 1 they would do 500, in year 2 they would have 1,000 patients, and like this. So within a matter of 5 years, they have 2,500 patients on their books. And to see these patients, they wouldn't have time to see the new patients. So these patients need to be discharged back to the community, which, as you know, in the UK happens in 2 years in the public health sector, and the private health sector happens at 1 year. Patients are handed back to their community. But it is also important that the patients are trained before they offer this operation, that they need to look after themselves, and they need to make sure that their nutrient status is good, because with a poor nutrition, they would not do well. They would have other effects of bariatric surgery, which might be difficult to manage if it is not picked up early.
Yeah. And the same issues relating to lifestyle and lifestyle challenges also apply to anybody who's had surgery, just as they'd apply to somebody who's had drug treatment or dietary treatment.
Absolutely.
That is one of the problems.
Yes, absolutely. It is not an isolated intervention, and I keep on emphasizing this, that bariatric surgery alone is not desirable. Bariatric surgery should be a complementary intervention with good lifestyle, with a healthy diet, with insightful, mindful eating, and the term here is mindful. For example, we all know that our body cannot process more than about 7 gram of, is it 7 gram or 7 teaspoons? I've forgotten, Tony, of sugar. We're talking about the amount of sugar that our body can process, and we eat far more sugar than that, generally.
I think it probably varies from person to person in terms of the extent to which they can cope with it metabolically and how they respond to it. I think it varies quite a bit. But you're absolutely right there. I think the changing composition of some foods, some popular foods, which were heavily loaded with sugar, may have helped a little bit. But you're absolutely right. The nature of the diet is really critical, and this is an area that needs to be addressed. Can't just be done from a health point of view, it's got to be done from a food supply point of view as well. Yeah. Can I just go back to one thing? You mentioned you mentioned gastric bands, and different countries have different approaches to bands. My understanding is that certainly a few years ago in Australia, more bands were done than, for example, in the United Kingdom, but that was because the system there allowed for provision of the resources for the review, which is required at intervals, to adjust them, whereas we don't have the resources in the UK for doing bands in the same way. Is that still the case?
It is still the case, because band is a resource intensive management after the procedure. So patients need to have an access, more or less open access. If they need a band adjustment, they should be able to see the specialist or a specialist nurse who can do the adjustment for them. We are fortunate at Whittington, we have got a specialist nurse and dietitian who can both adjust bands, and therefore I would hardly ever see a band patient after the operation, except in specific cases where they are struggling to adjust the band, or there is some specific complication that has developed. And that is the aim. The aim is ideally that these patients could be managed in the community with specially trained nurses and dietitians who could do the vast majority of the follow-up and adjustments and only refer those patients who have specific specialist need to the specialist hospitals. That is where we need to reach in order to provide a good service for these patients. Otherwise, we will fail. So if we can do that in UK, that'd be great. But as you know, UK healthcare at the moment is struggling, and we have got junior doctors as well as senior doctors who are moving out from the public health system, and therefore we are always struggling. We're always struggling.
Yeah. Let's move then to another area and think about developments for the future. Now, quite a few years ago now, engineers and surgeons developed an endo barrier, which was a semi-permeable tube which can be inserted into the small intestine on a temporary basis. And where it has been used, I understand that they have been able to demonstrate that they've achieved weight loss with, for example, remission of diabetes, and that the results have been sustained for a year or two. I think you have to take them out after 2 years or 1 year. But where are we now with things like that, which are an alternate to actually doing the surgery?
So I think endobarrier has at the moment fallen out of fashion because we don't have the technology to avoid the complication. The main problem, the technical challenge with the endobarrier is how do we retain it in place to avoid it from moving onwards, and to cover the part of the bowel that we need to exclude in order to achieve the weight loss and the diabetes remission effect. Sadly, we see these patients develop ulcers, erosions, and if we leave this, it's a foreign body after all, for 2 years, then there is a significant incidence of these complications becoming even more complicated, and maybe perhaps developing strictures and other problems. So that is where we are with endobarrier, but it does not mean that this is something which would not come back. To give an example, I mean, 100 years ago, even before the ICE, the internal combustion engine, electric car was actually the first sort of tried option, but it did not work out because we just did not have the infrastructure in those days. The batteries were heavy. We didn't have the charging infrastructure. But it is coming back because we have got the technology now. So once we get that, we get that sort of technical challenge resolved, how to retain it inside without developing those complications, then it might come back. But at this stage, I would not use it as a sort of preferred device. Maybe it may have a role in certain patients, but the vast majority of patients can be dealt with medication and other alternative measures.
Are there any other new developments that you could foresee being considered in the next few years? Any other
I mentioned about the endoscopic technique of suturing the stomach from inside, so endoscopic sleeve. It is not as good as the laparoscopic sleeve gastrectomy for obvious reasons, because the stomach is still there. It is just stitched from the inside to reduce the capacity. It can be of use in some patients, especially in some patients who perhaps may be a challenge because they had previous abdominal surgery, and therefore doing a laparoscopic operation may be more difficult. But there are other procedures also being considered, but at the moment the standard operation still remains the sleeve and the bypass. The vast majority of patients, endoscopic sleeve gastroplasties are done, but in limited numbers for a limited set of patients.
I'm going to conclude today by asking you one of my standard questions, which is, if I were to provide you with a very, very large research grant, what would you like to do? Are there questions that you would do, or is there a program you would like to sort of initiate and demonstrate that it works? So let's say £2.5 to £5 million. If you had that sort of resource, what would you do? I'm not saying to you that I've got it, but it's just an idea. It's a theoretical exercise.
I would team up with someone like you, who is an expert in this, and would ask you instead as to what would you like to do, Tony, because as you know, 4 to 5 million pounds may sound a large amount, but given the extent of challenge, it is going to be very difficult for us to do any meaningful research, large scale, that we need to do in order to establish perhaps why certain patients seems to do better than others. We know that in the same family there may be siblings, one of whom is eating very little and puts on weight, and the others are putting on weight even though they eat the same amount. So we know that there are differences in the environment. There are environmental aspects. There are the genetic aspects which make a person more prone to put on weight. And it'd be great if we can actually explore these in order to give our patients extra options which they can use to hopefully maintain their weight.
So what you're really suggesting is the development of a screening process whereby you can identify the best way of dealing with the patient's problem for that particular individual, those characteristics.
Absolutely. If we know that a patient is not going to do very well with with bariatric surgery because of their, just as I said, the environmental aspect we have already picked up. We know if they're doing shift work, if they're on psychotropic drugs or steroids, they will not do very well. So why would we offer bariatric surgery to patients who, for genetic reasons, would also struggle? And maybe these patients we could try and manage through other ways.
Okay. Last comment. In one of the earlier series, I interviewed Dimitri Pounaris, who's a bariatric surgeon down in Bristol, and one of the comments he made was that when I asked him the question, he said that he thought that despite all the problems, in the future there would be more bariatric surgery rather than less. Let me ask you the same question. A, for the United Kingdom and then for other parts of the world, do you think that we will be moving towards, bearing in mind the increasing population size, the number of older people who are surviving into a greater age, do you think that there will be more bariatric surgery or less in the future?
It depends on your time scale. I think that certainly bariatric surgery would rise in the near to medium term future, but I shudder to think that in the long term we as a society are not able to prevent our population from reaching a stage where they require bariatric surgery. I would think that given 20 years, 30 years time, we would do less bariatric surgery. Yes, we will do bariatric surgery, we would still do the same numbers. It's not that we're not going to do, we still do maybe 8,000, 10,000, 20,000 patients operating, but we hope that more patients can be managed in non-surgical methods. Surgery should always be a secondary option rather than the first option, in my opinion.
Mm-hmm. Pratik Sufi at Whittington Hospital in London, thank you very much. Thank you for talking to us. Thank you.
Thank you.
Bye-bye. Bye.
Bye.
Bye.